What's up, everybody? Welcome back to the Body Movement Podcast, episode 5. How about that? We're just getting going. If you haven't already, please hit the like and subscribe button down below. Join the community, join our early viewers. Thanks to everyone that gave our first few, we just launched last week. So that gave our first few videos a like or a subscribe or just a view. Really appreciate that. We talked about body movement, what it is, B.O.D.Y, built on developing yourself. We explained our philosophies. We talked about the healthcare system. We talked about cash-based practices, maybe being a solve to the problems that exist in the current system. We put out a little request to network with people in the nutrition and health and healthcare fields. So we're kind of getting going here. And so thanks to everyone that's been joining us. Episode 5 today with my sister here, the PhD, the physical therapist, the GOAT, Allison Sinikowski. We're talking more of some of the issues that exist in not just the healthcare system, but really it's a bigger overarching thing with just life when you're dealing with experts and the language we hear and how important that is in terms of our mindset. We're going to focus it on healthcare and nutrition and physical fitness, dealing with our providers, but how important language is that we hear from the experts that we're putting our trust in. And a concept I'm going to let you go off poetically on in just a minute is this word called nocebo. That sounds like placebo, where, placebos have positive effects on people when they think they're getting something, where this concept of nocebo is the words that you hear from your doctor or your nutritionist or your personal training might actually fuck up your mindset and put you off on the wrong path to fixing issues or achieving the goals you want, because you're thinking about the wrong thing, or you're not thinking about holistically, or you're thinking about it too narrowly. So this is a problem that we want to talk about. I'm going to let you give a little more context there, and then how important this is to then rectifying issues going forward. So I know this is a concept you've been preaching to me for years. And I find it's actually critically important, because the way you say things and the way you explain it to me, it's like, oh shit, like now I see it clearly that I shouldn't just focus on my back pain. I need to focus on my whole body, which will fix my back or something like that. So I'll let you get a little bit more eloquent with it, but we're really talking about this whole podcast we're doing is shifting mindsets and changing the way we think about things. And this is a way to do it where we're calling out health providers on a better way to treat people that they're getting their trust put in them. And this is a really important way to do it. So I'll kind of let you rant on that, but this is the concept we want to talk about today.
Okay. Yeah, we all know this word. Okay. So by definition,
yep,
a harmless pill, medicine, or procedure prescribed for the psychological benefit to the patient than for any physiological effect, meaning it helps your brain and your brain processes it and it says, wow, this was good. It helped me. Right. An example of a placebo is taking a sugar pill when you think you're taking Tylenol and it helps a headache go away. Right. Placebo. It didn't do anything at the physiological level, yep, but it made a positive impact.
Yeah. Now, and has it been proved, and this is just, again, this will be a recurring theme in the podcast of me just asking the stupid question of, like, we've all heard of placebos, but are there like legit studies like the placebo effect is real and it is beneficial to the person?
Sure. Yes.
Okay.
Do I have them tangible right now for you? No, but
no,
yes.
Yeah.
So how, in so many ways and more so even how positivity impacts people.
Right.
Just not, right. And it's like, it's almost like positive reinforcement versus negative reinforcement.
Yeah.
If you ask somebody, would you rather receive positive reinforcement or negative? They'll say positive. That's a placebo.
Yeah.
Okay.
Yeah.
Versus a nocebo is a detrimental effect on health produced by psychological or psychosomatic factors, such as negative expectations of treatment or prognosis. Okay. So we can digest those big words, but at the end of it, that just means if I tell you something negative is going to happen,
yep, it
probably will. So we could take the easiest example that's in my PT brain is, you have significant arthritis in your knee You are going to need a knee replacement within the next 12 months. Come back when you're ready.
Mm-hmm.
Okay.
Okay.
Nocebo.
I'm with you. Yep.
Huge nocebo. You're going to need a knee replacement. Okay. Well, I feel my knee hurts, whatever. Versus, we know that at age 50, there's a certain level of arthritis that's present in everybody's knee. We can see that is true for you.
Yep.
And, one of the best things that we know is strengthening the muscles around your knee and improving your movement patterns and helping you build up tolerance to movement can totally make you feel better, and your function can go up, and your pain will become background noise. So 2 things there. One is not to promise people that pain's going to go away, because that's, and I was just talking to you about this, like pain's a vital sign. So if we're like, so sometimes the nocebo could be like, take this and your pain will totally go away.
Right. And
because
when you're
if
saying
your pain doesn't go away, then you're down that your pain's still there.
Right.
So it's all the picture we're painting, right?
And when you're saying vital signs, everyone knows this is your blood pressure, this is your pulse, this is your breathing rate. We don't think of pain as a vital sign in a checkup, and pain is, what you're saying is, pain is normal, and it's okay to feel it. We just want to check how vital and where it is. Like, you might have an elevated heart rate, but it's high and normal. You might have a little pain. Well, that's normal for the stuff that you're doing. Right.
Right. So, and I think, challenging how people say all of those things. So I pulled up some examples that are outside of PT scope, because, I could go on PT world all day long, but one was two, it gave a nocebo and placebo. One is you have 6 months to live. Yep. And the other half of that was from the placebo was longevity can be increased by forming healthy habits. Mm-hmm. So, another one, you can get sick from eating that. Yep. Versus making better food selections will promote higher energy levels and better overall health. So instead of digging at the negative, number one, making people feel more like shit because they already know they need to change. Right. And then this, and versus giving them that positive reinforcement, that comfort, that understanding that you can do it and you can change it, and, things will be better, and, I think that carries to all people. And you and I have talked about this. It's not just healthcare providers, although we probably are the worst at it. It's everybody. If you talk to your friend about your wrist pain, and they're like, oh, I had wrist pain before, and it led to me needing surgery, and it was terrible. Right. And then you're like, shit. And then you go down the street and you talk to somebody else. It's total mind fuck. It's gone. A thought process that's kind of infiltrated just in the way that we talk as people. Yes. And we're not conscious of it. It's almost like second habit. It's a involuntary reflex to say, if my wrist hurts, it fucking hurts. Right. So it's like, that's what I'm saying. But if we're talking like this, we're making you say, hey, like, think about the words that are coming out of your mouth. That might just change the whole mindset of one, who you seek out to get it fixed, the approach you take to get it fixed, et cetera, et cetera. Yep. Yeah. So another, and we might get to this again, but just when we talk about image findings, or we talk about an injury or a body part. And image findings, you're saying x-rays or CAT scans. Sure. Yeah. MRIs, so like we'll go back to the knee arthritis one. Yeah. So, arthritis, osteoarthritis, we'll talk osteoarthritis, which is the typical arthritis people talk about, is very, very prevalent in most people. Quite frankly, starting at just after the age of 30, if you x-ray anybody's knee, over 80% of them are going to show arthritic changes. So one of the call to actions, we can come back to this, but is that as healthcare providers, now PTs, other than if you're in the military, aren't involved with imaging. We can't order it. We can't, we have a little training in reading it. Right. But those radiologists or physicians that I, work with the closest, that I really respect, are asking people when they report MRI or X-ray images to use what we call CLEAR principles. So CLEAR is, an acronym, and it stands for using consistent language, and you give epidemiological information, which means you're 50 years old The normal 50-year-old has more arthritis than you. That does not have pain. So these are findings of people that don't have pain.
Right.
So there's plenty of epidemiological studies that show what a normal film looks like, what a normal x-ray looks like on healthy people who are not complaining of pain.
Right.
So if you get an x-ray and you're like, okay, you have mild changes, arthritic changes in your knee, automatically, if you don't know, you think that's a terrible thing. Oh shit, I got arthritis in my knee. Oh my God. Versus, yeah, so your x-ray does show a little bit of arthritic changes. That is actually totally normal. Most people by the age of 40 actually have this, if not more, arthritis in their knee, even without having pain. So that's probably, not the main source of your pain. It's a different feel, right? And then the last part of that is the assessment of relevance. So do the clinical findings of an image align with what you're feeling? And this we could go so many directions on, and I won't go too deep, but a great example is if you image your back and it shows a disc herniation, and you have nothing that's presenting like a disc herniation at all,
right?
Then suddenly you think you have a disc herniation that's creating your pain, when really it's that you need to move more and walk more and strengthen your muscles.
And that's what our podcast is about. We're like, hey, a lot of these problems that we're seeing in life are, maybe you do need surgery, maybe you do have to do some rehab, but just moving your body. And what we should say in future episodes, we're going to be doing a ton of demonstrations on primal body movements and movement concepts that will just kind of get your body feeling better. But so there's an example of you're already thinking I got a disc herniation when you may or may not, and that the problem is to go see a specialist and somehow get a quick fix. And it's like, hey, we're going to have a bunch of routines or regimens or exercises or functional tests that you could do by moving your body that might even alleviate some of that pain, might correct the issue, might highlight where the real issue is, whatever it may be. This is an example of where the mindset and what you're thinking and what language has been said to you or where you think the pain is, knocks you off the path of getting to the best possible outcome for you down the road.
Yeah. And I think, you and I will have some language battles sometimes because I do this. And so like every time we say fix somebody, I want to punch you because it's you're working on your ways, you're bettering yourself, you're changing the environment in which you live by everything you do. So a lot of times the best way I like to approach it with somebody, because again, I don't want people to think they need and have to be pain free. I want, or whatever their issue is, but I want them on the journey of understanding what the best habits are that give you the best chance of feeling great. So, when somebody comes in with pain,
that's a totally different. I mean, I just said fix, didn't right?
Like 5 times. Yeah.
I keep saying it, right? Because that's what's programmed in me.
Yes. Yeah.
Right.
Yeah.
Yeah. So we're gonna have language battles because is this a nocebo? If I say, hey, if you get knee surgery, whether you need it or not, and this will fix you, and then you get knee surgery and you have issues after that, which probably happens all the time.
Fucks up your brain.
That fucks up your brain because you're like, this should have fixed me.
Right.
Yeah. Okay. So this is part of the podcast. It's like, I'm representing everyone that's listening right now who's sat in a doctor's office.
Right.
I'm healthier than the average person. I have a fitness background, but I'm not a provider, right? I'm not a teacher of this. Like, that's why we're talking to you. So it's like, I'm sitting here on your podcast we're trying to teach people how to get better. And I'm saying a word that has been programmed in everyone's mind, including mine, of you're going to get fixed. This instead of that. I'm exacerbating the problem. And so this is what we're talking about, how important that language is.
Sure. So let's say you were in my office as a client, we'll keep rolling with the knee because it's easy, but you're saying, oh man, I had knee surgery. Yeah. I had a meniscus tear.
Right.
And I had surgery to fix it and they got it out of there, but I can't, my knee still hurts.
I'm already
Did
laughing.
I re-tear my meniscus? Right. No, like, let's watch you move. Oh, wait, you can't squat. Oh, and again, me saying that, we actually just had some nice conversation in one of my groups I'm in, where we post cases and stuff. And like me even saying that, like, oh, you can't squat, like, is terrible. Like,
well, then it's like,
and I don't do that.
It's even the way you structure questions. So I almost feel like we're tearing down the entire language though.
Yeah.
It's because this is just the way we talk. So let's go back to your first example when we just started the podcast, this episode, and you were like, okay, there's something wrong with your back or your knee, and you're going to have surgery in 12 months, right? That already plants in the person's mind that this is the option. I'm on that pathway.
Mm-hmm.
It is still possible that person does need knee surgery,
mm-hmm.
right? So where is this fine line of being upfront, being honest, telling the patient exactly what is going on so that they're informed and know this, whatever, and I'm going to pick the wrong words, but this is wrong with me, or this isn't functioning optimally, or this is something that does need to be corrected.
Right.
How do you communicate that clearly and effectively so you're not sugarcoating it, so that you're being honest and upfront so they know there is some sort of issue?
Yeah.
And that they're simultaneously, you're not going to ninja, you're not going to fuck their brain up for however long.
Yeah.
And you give them a realistic, pathway to feeling better. Can I say feeling better? You know what I mean? Like,
So this is my common terminology or common conversation. And again, this isn't my script. It depends on the person in front of me. If I have an engineer, I'm going to talk differently than if I have somebody that's a similar brain than me, that's all over the place and it's just like, yeah, cool, whatever. Right. So if an engineer wants like nitty gritty specifics, I need to meet that person where they are.
Right.
And one of my colleagues posted something last night that fits perfect. It's like the goal is the goal, but it's not my goal. It's your goal. What's your goal? Mm-hmm. So if somebody starts coming, very rarely will people come in with pain unless it's impacting their life. Right. So first of all, we got to know what's important to this person. If it's the fact that they can't run, and I think we said this in maybe one of our first ones, they can't run and they've been on anti-anxiety meds prior and running got them off of those, they need to run. So, so a lot of times it's not that we disengage or disregard what's happening, but it's just making that people see a possibility. So simply by talking to them, simply by stating what are some common findings in people their other age groups, like, okay, so you have a meniscus tear, you didn't have a mechanism of injury. Really strong research shows, and sometimes I say this stuff and sometimes I don't because some people get lost in it, but a meniscus tear a year out with conservative care versus arthroscopic surgery, results are the same. A year out. So but we got two issues with that.
It's the cost benefit analysis. Yeah, keep going.
Great. So cost benefit, we can dive deep in a rabbit hole about cost, which we won't do today.
What you just did there is you're already giving an example of like, hey, there's more than one option. I want you thinking about this, and I don't want you dwelling on, all right, I got to get myself prepped to go under the knife.
Yep. And then it comes down to, what do they do well? Mm-hmm. So let's say I can't squat. Okay, let me see you lunge. How's that lunge? It feels great. Sweet. Let's stay with the lunge. I did this with Aaron yesterday. This hurts, that hurts. Okay. All right. Got it. Can you do this? Yeah, I can do that. Sweet. Stay there. Do lunges. Let's do lunges. Here's some weight. Build your strength with lunges. Now, squatting's inevitable. Can we find a way that you can squat? Can you do a wall squat? Can we raise your heels up? Can you hold on to something? And all of a sudden people hold on to something and they squat their butt to the ground. They're like, yeah, that feels fine. Oh, so you can squat. Got it. It's just that squat that hurts. Cool. Let's stay away from that one. And let's work over here. And let's build your strength up and we'll move you, tick in that direction. Now, over time, so you got to find a nice path of finding things people can do well and so they feel good with movement. So they're positive when they're moving versus everything hurts. This hurts. Well, okay. People come in your door. They know exactly what hurts. You start to ask them what feels good. And they're like, I don't know. So again, negative. Like we all know what hurts. But then after that, when you set expectations, One, we kind of talked about, like, I'm not going to tell people they're going to be pain free, but I'm going to give them a rehab timeline.
Okay, I think that's a good stopping point. We took this conversation and divvied it up into 2 parts. So episode 5, you just finished. Episode 6 is part 2. That's also out on YouTube right now. So if you could go over, give that one a view, like it, subscribe to our channel, that'd be great. Here in episode 5, part 1, we just wanted to talk about what a nocebo is, define it, give you examples of it, so now you are aware of it. Episode 6, which is part 2 of the conversation, we just continued this, but now we said, now that we know what a nocebo is, how can we be more aware of them as customers and as patients, and how can we ask better questions to our providers and challenge them to provide us with the best care. So if we're more educated, we'll get the best out of our providers. And then we made a call and a challenge out to the healthcare and the wellness industries to be better with your words, communicate more frankly, be honest, but set realistic expectations. And by doing that, the outcomes of your patients and your clients will be better. So we hope you enjoy that. Go over, give the episode a view, and we will see you in future episodes. Thanks again for joining us.